Good morning to everyone. Good morning, good afternoon, good evening, good night to all who are watching this. I'm Dr. Deva. I'm a psychiatrist and a professor of psychiatry at the University of Rahman in Malaysia. Malaysia is basically a developing country. And over the years, as a psychiatrist, I've learned that there are some things that I have experienced in the teaching of psychiatry and the practice of psychiatry that I would like to share with others in the low and medium income countries of the world. So I've called this presentation as Adventures in Transforming Psychiatry. It's actually an account of how we started the practice of psychiatry in a different paradigm or different setting from what we were used to many years before. And then goes on to describe the differences that we have managed to create in some other low and medium income countries, which are conducive to good practice of psychiatry, rather than what is happening in many countries where mental health is heavily stigmatized and psychiatry and psychiatric patients are heavily discriminated. This presentation is with the assistance of my university, University of Rahman, whose logo you see on the left. It is named after our first Prime Minister, our founding father in Malaysia, and the Asian Federation of Psychiatric Associations, which I founded in 2005 to help improve psychiatry in the Asia Pacific region. This was what surprised me in the 21st century and even before, that psychiatry, even in a high-income country in Asia, was being treated in locked doors with very restrictive kind of setting that not only was discriminatory and bad for the patients who were suffering inside there, but even more was actually training students, medical students, nursing students, healthcare workers, that psychiatry is something that is a dangerous profession, with settings like this where security was very important because psychiatric patients are dangerous. The word psychiatry actually encompasses about 450 diseases. Out of these, only 7% or less are related to dangerous patients. In other words, psychotic illnesses. Sometimes organic, but most of the time psychogenic. It's like schizophrenia, manic depressive disorders, organic brain syndrome. Because of the nature of these dangerous diseases, they needed hospital admission. This started centuries ago in all parts of the world, in Europe, in other parts of the world. But even in those days, there was an enlightened approach to the treating of mental illness in many parts of the world, including the Middle East, in India, in China. Mental patients who were disturbed, were sometimes violent and aggressive, were treated with calming, soothing treatments, which did not include this incarceration, as went on, as goes on even now. I'll just give you a very brief introduction about myself. I started training in psychiatry in 1970 after graduating from medicine in 1967 in India, and spent a short while in the Army and National Service in Malaysia. I chose psychiatry after I was asked to look after a ward for prisoners, which also included psychiatric patients in a general hospital in Malaysia. And after that, I requested, after my army training, I requested to join the University Hospital, which is a new hospital, the first medical school in Malaysia. Doctors were being trained in Singapore before that. In 1957, Malaysia became independent, and we started our own first medical school in 1966. I joined in 1970, this medical school and the university hospital where the students were being trained and nurses were being trained. And that hospital was a turning point in my life because the management of psychiatric patients, diagnosis, treatment, and follow-up was done in a non sort of incarcerated atmosphere, as was the case before. Psychiatry was always treated in locked wards, barbed wire, and all kinds of things. But this ward was in a general hospital, large general hospital building on the 5th floor, no locked wards. What happened was there was a lift going in and out of the hospital. And this was not even guarded most of the time. So very rarely patients would try to escape from the ward. But most of the time, the patients would be treated very quickly with the newly available psychiatric medicines so that they did not have a long period of disturbed behavior. What we also did was that compulsory admissions, according to the mental health law, and forensic admissions for patients with patients who had committed crimes were absent. We deliberately decided this is going to be a voluntary ward. And with that, we had very quick diagnosis and quick treatments. And within 24 hours, most of them were calmed down, maximum for about 48 hours. And within about 10 to 12 days, most of them were sent on leave, no matter how aggressive they came. And after leave for 1 week or 2 weeks, they would be discharged. Very rarely they came back and were readmitted. The medication used and the diagnostic criteria were very active. We did not put a patient in and wait for 2 weeks before we started treatment. So for many, the short inpatient stay was not enough. And in June 1971, we started the day center, where the longer term psychological problems of such disturbed patients could be carried on through a day center, which is an open center, no locked doors, nothing. Patients came from outside, initially from the ward, but eventually from outside, and attended day programs, social, psychological, and occupational rehabilitation, and were discharged and eventually into whatever work they had, or were put in a sheltered workshop where they were trained to get jobs that they could obtain in the community. So occupational therapies, group therapy, sheltered workshop added on to the short inpatient stay. And this is how I experienced my first 2 years working in a psychiatric ward. Not a locked ward, no barbed wire, no locked doors, no steel doors, and no long stay. The average length of stay was in the beginning about 21 days. That included the going home on home leave. By the time I left 20 years later, or 28 years later, the average length of stay was about 11 to 12 days. So psychiatric patients, no matter how disturbed they were, could be managed with accurate diagnosis, accurate treatment, good medication, and a day center in a relatively short while. Not the 1-2 years admission for a mental hospital in those days in most developing countries. These are pictures of the university hospital that I worked in. And on the 5th floor was the psychiatric ward. which is somewhere there. And these are other wards, medical, surgical, orthopedic, gynecological wards. And this is the primary care center. And this is the car park. This has changed a lot now. There are many, many more buildings now. This is an old picture to show you what it was. This is our daycare where patients, we had a German doctor who came to work with us, and he learned how we manage the daycare center. And these are patients from inpatient wards, medical officers, nurses, and outpatients who came as day patients. And then we had various activities there. There's singing, dancing, occupational therapy, craft work, playing games outside, inside. And the day patients came from 8 a.m. to 4 p.m. and on weekdays only. Weekends, they stayed at home. So that what we call milieu therapy, a change in the atmosphere of the recovery of the patients was the mainstay of our care. So short inpatient stay for less than 2 weeks and day center for anything like 2 to 3 months. But they'll come initially once a day, then eventually like once in 3 times a week, 2 days a week. And by the time they finish at about 10 days, they'll be coming like twice a week. That's all. And the patients were discharged. So this is a model that was relatively new in the low-income countries those days. And this is what I was brought up in as a young medical officer. I went overseas after the 2 years of training in Malaysia, worked in Edinburgh as a trainee and graduated and came back as a lecturer. And I worked in the University of Malaya for 28 years, including training overseas. And that's how I started my work in trying to change psychiatric treatment and training for the rest of my life. We had other activities, like I said, we had cooking, we had craft work, we had even industrial work. We actually got industrial work and used that to improve the rapid recovery of the patient from what was actually, most of them were quite psychotic when they came in, schizophrenic. At the same time, in the other rest of the country, we had a hospital like this. It's a large mental hospital with about, when I first started training in 1971, they had about 5,000 patients. Steel bars everywhere, patients being looked after by guards who are dressed more like policemen. But even there, they had occupational therapy going on, making craft work, doing rattan work, and so on and so forth. You can see how in those days, the 1950s, patients actually helped in the occupational therapy of the hospital. It looks rather drab, and patients were probably coerced to work here. But at the back here, you see a little shed, sort of like a lampshade. This is actually to prevent patients from climbing up, to electrocute themselves, to commit suicide. When electricity first came about in the 1930s, many of the patients who were so frustrated living in a mental hospital wanted to commit suicide. Those days, there was no medication. There's no antidepressants, no antipsychotics, and so on. But these is ancient history. And this picture here shows much later in the 1980s, still in one of the small hospitals, we had a psychiatric ward which was full of barbed wire and security. But from this, I decided that we should try to change it. So with my colleagues and my students, we went out over to the hospital to try to change that. We went to this hospital, this large mental hospital with 5,000 patients, with our postgraduate students, and gradually got them to try to change the anonymous wards like this, long wards, no privacy, no cupboard to keep their things, no combs, no slippers. Well, really very, very inhumane way of treating patients. So with a very little money that we had, about $200 US as a postgraduate fund, what we did was we divided this ward into smaller cubicles, more privacy, more curtains. Patients were introduced to group therapy. There were patients for about 15 years in the mental hospital. Gradually, we got them out of this institutional care that was there. These are some of my students. These are the nurses. They're very helpful. We got a lot of support from the nurses. Without the nurses, we couldn't have done all this. All these screens were actually given by the nurses, and we decorated them with pictures to make it more conducive. Psychiatry doesn't have to be a drab and almost like a jail. It doesn't have to be like that. Patients are lying down like this in the middle of the sun, sick and totally uncared for. Inhumane kind of treatment. We got them involved in occupational therapy, games, although they're relatively old, but we got them involved. We got a young occupational therapist who did a marvelous job changing the attitude towards the mentally ill and making their lives more meaningful. In those days, I traveled quite a bit, and on one of my trips to Thailand, which is north of Malaysia, I was shocked to see that a mental hospital looked like this. Like this. Not what you saw earlier. Just remind you, just go back a little bit. This is how our mental hospital was, like a jail. What we did was, I went to Thailand and I saw this is a mental hospital. I couldn't believe it. In fact, it's a bit small here to enlarge it, but doesn't matter. This hospital is called in English Garden of Living. A very wise Thai psychiatrist had given this name, Garden of Living. And outside it looks like any government department or beautiful government offices. And here in Thai, it's written the same thing. I went inside and got a greater shock. Inside was really a garden of living. Beautiful flowers everywhere, trees planted. It's a tropical country, so it doesn't look like a mental hospital. It looks like some garden city. I came back to Malaysia, and this is how our hospital was. You can see the difference, between this and this. So I challenge our doctors and nurses. Look, why can't our hospital be like this? Oh, there was a debate. And some of the senior nurses said, this is exactly what we want. But the hospital wouldn't allow this because they said patients will eat up the flowers, they'll destroy the gardens. Some patients will climb up the trees and hang themselves. No, we cannot allow this. Mental hospitals should be like this, bare, drab, no bathroom, no privacy. They bathe here naked. Anyway, they discussed. I didn't work there. I go there only to teach my students, my postgraduates. When I went back 2 years later, the nurses had prevailed. And this is how this became this. This was only possible if not for the wonderful work done by the nurses. There's nothing wrong with the staff there. A few staff, yes, they may be very paranoid, very suspicious, very reluctant to change. But there are enough nurses, enough doctors who are willing to change. But they must be shown the way. And that's what we did. We changed them to this point where the nurses did all this. They planted trees, which was so tall and nice and beautiful, but of course nobody can climb that, as you can see. They planted flowers, bougainvilleas. Not only that, they actually sold these plants outside and made money for the patients. So in a tropical country, this is possible. Of course, the patients couldn't eat the flowers because they're bougainvilleas full of thorns. So this was what we achieved. This was what we achieved. This is what is possible in a drab, security-conscious mental hospital. Why can't low-income countries do that all over the world? because attitudes are such. Get out. Dangerous. Don't trust the mental patients. Well, we showed otherwise. They took up the challenge and showed years of practice were wrong. We went one step further. One advantage I had was that I was quite senior. Many of the doctors who worked there as psychiatrists were my students. And so when I went there, in Asian countries, people respect their teachers very much. And I went there and I suggested to them, I know you have got huge, large mental hospital with very archaic systems, but I think we can do more. These patients are doing well. The atmosphere has changed. The flowers and the gardens, everything look nice. Next step is, can they be made useful, the patients? Can they earn money? Oh, mental patients, how can they earn money? They're dangerous. No. I said, maybe we give them the better patients, better work, do some simple things. And Malaysia is a developing country which has got lots of industrial subcontracts we can get. So we got some of our doctors went out to the factories and worked with them and said, can we do this? Any developing country has got enough work to be done by anybody, and mental patients can do it if we show them the way, train them, and supervise them. So we got subcontracts to make tube lights. These tube lights, the tube lights, and these are people making tube lights. These are forensic patients who have been brought to mental hospital, but not only mental illness, but actual problems of injury and murder. They ended up being very good workers. No problem, nobody hurt anybody. Of course, they wanted treatment, and they made tube lights that were sent back to the factory and sold all over the world. We also got nurses, the nurses to get contracts and the doctors to get contracts for very simple craft work. These are actually boxes of incense for Chinese temples. The boxes need to be made. They brought in the cardboard and it was all clipped together, and these patients were given ordinary clothes. They were allowed to wear ordinary clothes and clip these boxes, and they got paid for it. These are parts for television sets made with simple equipment done by patients, and they were paid for it. So it's not just getting rid of the signs and symptoms, but actually become productive and useful, which is a tremendous rehabilitative effort for mental patients. So this is what we did. And lest we forget, because at that time we were starting a kind of revolutionary effort to change the practice of psychiatry and the teaching of psychiatry, to show medical students and nurses that mental patients need not be useless. A lot of things can be done. So we collected the old pieces of restrictive movements and beds and all that sort of things and made a museum. And the students, my postgraduate students, made that museum with the help of the hospital, large mental hospital staff, who were very enlightened. And they collected all these things and we put it in the museum, and that was opened 25 years later. This goes to show that many changes in this world, especially in mental hospital, takes a very long time. So now we have a museum. It's opened by the Sultan of the state of Perak, where the hospital is, and it's 25 years later. And these are students of mine from another batch. I took them there to show them what the museum is all about, the details of which are too long to show here. Now let's move a little bit away from this, my adventure. After I stopped working in University of Malaya, actually I worked there even after I retired. I was re-employed until 1998. And I was asked to go and work for the World Health Organization in Manila. They asked me to go and help develop some changes in the mental hospital system in Mongolia. Mongolia is a very large country very small population, about 2 million people, huge area, one end to the other, north of China. One end to the other is about 3,000 kilometers. More, maybe about 4,000 kilometers. And very harsh climate. In winter, it can drop to minus 35 to minus 40 degrees Celsius. And they're just coming out of the socialist economy and they're going to a market-driven economy. So money was at a premium. How could you change the mental health of this country? They had followed the old system where psychiatrists trained in a different system, but were in fairly good numbers, but not in the modern system of rehabilitation and deinstitutionalization. So I went there and with the help of WHO and funding by WHO, managed to change a number of things in this very difficult, harsh climate. The people's main occupation there is herding of animals, cows, horses, yaks, camels, sheep, and so on. So we use that to change the livelihood of the patients and set up rehabilitation programs in many parts of Mongolia. Herding animals, patients actually involved in recovering as part of their illness, we got them to get involved in this. And the horses and sheep are owned by the hospital in a rural area. Camels and so on, plus a lot of craft work done by the patients and a little bit of vegetation grown. Of course, we couldn't do very much because the winter is very long and the summer where we can grow vegetables and things are very short, about 5 months at maximum, maybe about 4 months. And some craft work that the patients could do. And gradually the patients got better and many of them could actually go out and earn a living working in the rural areas looking after the animals. To do this, we had to set up gurs. Gurs are actually tented houses, which are, or yurts. In America, they call them yurts. And these were used for their rehabilitation in Mongolia. It's very difficult. There are very big problems in getting things organized. The WHO said, we cannot give money for houses. We don't provide houses. We said, look, we can't do rehabilitation without having this kind of building. These are tented houses. They're relatively cheap, about $1,000 US each. And the patients can live there and start doing all this farming and all this herding and so on. Very difficult to get the money, but eventually with some help of the staff in the WHO office, we managed to get some money and we got this. Today, with the help of several NGOs and voluntary organizations, we've got 20 such gurs used for rehabilitation and lots of patients are involved in getting the patients much better. Now we move to Fiji in the Pacific. I was invited by the Minister of Health, whom you see here. This is the Minister of Health. And this is the Dean of the Medical School, the Fiji School of Medicine. And they invited me to come and improve psychiatry in Fiji, which did not have a training program. There are very few, there were only 2 psychiatrists trained in short courses in Australia. And so the first diploma course in psychiatry was started here. And these are colleagues from Australia. He's an Indian psychiatrist from Australia. This is a Fijian psychiatrist, who's one of the 2 doctors there then. This is another Filipino psychiatrist working there. This psychiatrist from Australia, and was a volunteer from America. He was working there. He's actually in the healthcare, but he's not a psychiatrist. He was there under the Peace Corps. He was working there. And this is a Fijian psychiatrist. One of the 2 Fijians were psychiatrists. This one and this one. So I went there, got this program started. This is a psychiatrist from Taiwan, another one from Taiwan. He's actually from Malaysia, but he's settled in Taiwan. And we got this program started, postgraduate course. So with great difficulty, and at that time, Fiji had a very difficult period when the government was run by the military. But we managed to get to change the mental health law and also start the Fiji training program for producing diploma level psychiatrists. There was a big shift. Mental health NGO was started called the Fiji Alliance for Mental Health, and in 2011, and the first lady opened it, and medical students were involved in making awareness about mental health to the public. Mental health clinic was started in the community, and this is the dean and the Minister of Health, that's myself. And then that led to the opening of 3 stress management wards. First time in the history of Fiji, we managed to get stress management wards outside of the main mental hospital at St. Giles. Today, there are 3 such stress management wards. We changed the name. It's no longer a mental ward, the psychiatric ward. It's called stress management to make it less stigmatized. And then in Cook Island, we had a psychiatric nurse who was trained in New Zealand who came back. And there was no psychiatrist in Cook Island, but she started a program by which she could actually run a psychiatric service based on an NGO called Te Kainga. And this Mrs. Mariana actually got a building started because there was no money to build a center, a psychiatric clinic and center. And this center was built by voluntary help from a church and volunteers, and about 3,000 New Zealand dollars in cash. Built a building which was used as a stress management center. And she got some of the wood from the church and some donations, equipment, people donated crockery and all sorts of things. And this is how the day center started in Cook Island. But to run the day center, we needed money. And so Craftwork was started. I gave them ideas about how you can earn money by selling these to the tourist market. And they got money from that. And donations of food and things were used to help the patients get meals during their attending of the day center activities, craft work, group therapy, Alcoholics Anonymous, and so on. All done by the Te Kainga members. And Mariana helped us to get this program of psychiatric care going. Today, that center is expanded to 4 buildings. 2 of the buildings are donated by the government of Japan. The other 2 are by local expenses, local help, and buildings with the help of the carpentry school. And these 4 buildings are now in operation in 2 different islands. And what did the government of Cook Island do? They provided Mariana with the salary. Although she's not actually, she's working for the NGO, but she's given a salary. And that way she could manage the psychiatric services until just something like 10 years later, they now have a psychiatrist trained in Fiji. And they have a psychologist for the government, the Ministry of Health. And a psychiatric ward is being built. As far as I know, it's not ready yet. But the old cell that was there before has not been used as a psychiatric center. So tremendous achievements by the hard work of a psychiatric nurse where there was no psychiatrist. Now, back to Malaysia, I after a lot of experience in teaching psychiatry to medical students, to nurses, I decided to move to the bigger problem of primary care psychiatry. The 7% of mental patients who are in the psychiatric wards, psychiatric hospitals, nothing compared to the 65-70% of mental patients who are in the primary care setting. Lot of patients. The clinics are full, stress related, a lot of problems with family, money, jobs, marital problems, and now, of course, COVID, a lot of problems. And so we started a stress management clinic used for the actual training of medical students about stress-related illnesses. To do this, we set up just a large container. Total cost about $1,800 with an air conditioner included, and the electricity supplied by the government primary care center nearby. The doctors and nurses were marvelous. They helped us, give us a piece of land, very crowded, but a piece of land, and electricity provided, and the students were able to. And now that we have COVID, we have a hybrid system by which, because of the distancing, we can only see one patient and 4 students at any one time. The rest see online. It's directed by online teaching and training. And this way we learn history taking, management, relaxation exercises, and so on. And these are pictures of the actual practice of the patients being seen in the stress management clinic during the COVID times. So COVID has not stopped our management of psychiatric problems in our primary care patients. Actually, we are doing it exactly the same, hybrid system. Students, they're fully masked with distancing and sterilization of everything. And then other students outside listening to it, and then changing over after 2 hours, they come back and see again. And because it's a teaching hospital, I have to innovate ways of doing this. And there are the students outside in the stress management center that is used for training of patients in primary care psychiatry. We've also done work in Cambodia post Civil War. This was the 1990s, with help of colleagues from different parts of Southeast Asia and Norway in training the first batch of psychiatrists for the for Cambodia. And these are the first batch who have graduated. Now there are 50 such psychiatrists graduated since 1995. And at least, I think, 50 or 60 psychiatric nurses now available. And these are some of the students I trained in a developing country, war-torn country, which is now doing very well. And use some of the pictures that I have as training for the staff and the nurses and the doctors. And this is the day center that they started with my help and money from Germany and IOM, International Organization of Migration. And this center was started before they had their first war. They had a day center in Cambodia. Similarly, day center was started in India, in Nitte, with the help of a friend of mine from Australia. He's a psychiatrist from Australia, but actually he's born and brought up in India. And his wife is a lawyer. And the two of them have volunteered to come and start a day center with the help of Nitte University in South India, in Karnataka. And again, a partnership between interested people, passionate people, and they called me for help to determine how to do this project. We did that, and we did it. So, dynamics and transformation of psychiatry requires a certain degree of commitment and passion. As long as teachers, places of teaching, and methods of teaching do not change or remain in status quo, psychiatry will not change. Seeing this locked up wards, security conscious, and not bothered about the future recovery, rehabilitation, and success. As long as that is not the priority, and locking up and incarceration is the main agenda, nothing will change. No number of walkathons, mental health days, art competitions will make any difference. NGOs and conferences are doing their best, but we cannot change the practice of psychiatry until we make a paradigm shift in the practice. We have got to think different. We've got to practice different. And mind you, this is not theory. It's been done. All these pictures I showed you in Mongolia, in Fiji, in Cook Island, actually worked. If it can work there, why can't it work in your country? That is the challenge. That is the paradigm shift that we're looking for. The summaries above show that the cost is not the big issue. Most is, oh, we need more money. No. Money, yes, is important, but not that important. For $1,800, we can start a stress management clinic. No doubt, if WHO gave us tens of thousands, which is much more, we could do more. But even then, a girl yurt for rehabilitation in Mongolia cost $1,000 each. To get that $10,000 was very difficult. But we got it. And then seeing the success, some NGOs from overseas said, look, we can do that. So they gave money. One NGO from Belgium actually donated, I think, at least 4 or 5 girls like that. And then it took off. So we got to make that paradigm shift. Then we can move on. So money is not a big issue. Far more important than following the examples is following the examples rather than follow from the high-income countries, which have got enormous resources. If we had that, we could do that. But the high-income countries have got different experiences and different priorities. So with the limited resources, we can still do things. If there's a will, there's a way. So thank you very much for listening to me, and I hope that you can benefit by this. The emails are given here. Most happy if some of you can write to me. I can actually send you a book. This is just a recording, just a PowerPoint. I showed you a real book. It contains more detailed view of this, about 160 pages. Thank you very much. Thank you.